Hey everyone. So that was fantastic. It's 10 o'clock. We're going to jump in probably straight into the next lecture. We're excited. We've got Jason Ellis with us today.
Hi everyone.
And can you see and hear him? Great. So Jason is one of the cerebrovascular neurosurgeons at Lenox Hill, and he, in combination with Dr. Langer, Dr. Ortiz, Dr. Cerule, are going to really be kind of piloting this cerebrovascular virtual OR. Today's our first one. And these are going to be a mix of things like didactics, videos like we talked about. Should all in all be a educational experience. When we can, we'll try to get as much operative experience as possible, but obviously it's difficult with these times. So with that, I'm going to let Jason take over. And then to follow, don't forget, we have our first tech innovation lecture. We're talking about artificial intelligence and neuroimaging. So very cool stuff by Christopher Filippi to follow. So stay tuned. All right, Jason, all you.
All right. Thanks, Randy. I'm going to share my screen with you guys. Give me 1 second. Well, hopefully everyone can see this. Randy, stop me if you can't. Welcome, Brain Turns. We're happy to have you. It's going to be an excellent 8 weeks, and we have multiple cerebrovascular lectures and experiences, virtual ORs in store for you. First lecture in the cerebrovascular series is an introduction to intracranial hemorrhage. So let's just jump right into it. I'll make this bigger. So when you start talking about intracranial hemorrhage, that's a very broad category of brain bleeding, okay? But we can categorize it even further based on the compartment within the skull or brain that the bleeding has occurred. So here are the bulleted areas that you can have bleeding. You can have epidural bleeding. We'll go through that in further detail. Subdural bleeding, subarachnoid hemorrhage, intracerebral hemorrhage, and intraventricular hemorrhage. And let's just get into some basic anatomy so that we understand what those terms mean. Obviously, the outer part of the head is the scalp. Just below that is bone, or the skull bone. In the normal state, tightly affixed to the inner part of the skull is the dura, which is a thick outer covering membrane that surrounds the brain. Just beneath the dura is a web-like membrane called arachnoid. And then a layer that's really just tightly opposed to the brain cortical surface is called pia. Okay, so the three membranes you want to remember just inside the skull are dura, arachnoid, and pia, in that order from most superficial to deepest. Okay, and if you think of those layers, I think it'll help you understand the categorization of where brain bleeds are likely to occur. And by the way, the dura, the arachnoid, and the pia, those form the meninges. Okay. So if we were to look at some conventional brain imaging, such as a CT scan of the head, which you see here, and an MRI of the brain, which you see here, we can try to go through some of those layers again. Outer part, most superficial part of the head is going to be your scalp. Just inside of the scalp, you can actually see a little bit of muscle here. It's a little bit more dense than the rest of the scalp. Back here, you don't see any of that muscle. This is the temporalis muscle. It's involved with chewing. If you're chewing and you put your finger on the side of your head, the temple, you'll feel that muscle moving. Just beneath that, the white is the skull, very dense. and that's why it appears so white and bright on the CAT scan. The layers of the meninges you can't see very well on a CAT scan in the normal state. So it appears to go just from bone directly to brain, but we know based on our understanding of the actual microscopic anatomy that, and actually gross anatomy, that there is a dura, the thick outer covering, followed by arachnoid, followed by pia, but you can't see it here. In some bleeding states, you will be able to make out those layers, and we'll see that a little bit later on. Here's the MRI, which sort of reiterates the point. There's scalp, muscle here. There's no muscle here. There's bone, and I think the MRI shows you in a little bit greater detail the layers of bone, actually. The really dark layer here is the outer cortex of bone. The white is really the bone marrow. So there's a medullary component to bone, or the skull bone. Then there's an inner table of the skull bone. So there are kind of three layers there that you can see of the bone. Just inside the bone will be the tightly opposed dura mater, followed by the arachnoid and the pia just on the brain surface. And obviously this is the brain, okay? So to drive home the point, this is a picture during surgery. The scalp is being retracted here, open. The skull bone is exposed, and actually a craniotomy has been performed. And just after the craniotomy is done, right beneath it is the dura, the thick outer covering. Here the dura has been filleted open, and that shows the brain just beneath. That potential space between the dura and the brain is really that subdural space, and you can get bleeding there, which you'll see later on in the lecture. So let's go through some of the classic types of hemorrhage. This is an epidural hemorrhage or hematoma, okay? So epidural meaning above the dura. So while in the front part here, you can't really make out that dura because it's so closely opposed to the inner table of the skull. Back here, where there's an obvious hemorrhage, we know that the blood is really just pushing into the dura mater and pushing into the brain. And we know that based on the characteristic shape of an epidural hematoma, which is classically convex, okay? So really not adhering to the surface of the brain, and I'll show you a type of bleeding that does that, but really pushing it and causing this, this sort of lens shape appearance. Classically, epidural hematomas come from arterial bleeding, and specifically in this location, an artery called the middle meningeal artery, okay? And that artery sort of runs just inside the inner table of the bone in the temporal region, and it extends into the parietal region. If there's any disruption of that artery, usually from trauma, it can cause accumulation of blood just above the dura and rapidly result in this type of hematoma, which can be very deadly. Subdural hematoma, on the other hand, has a different appearance. You can see that the subdural hemorrhage is really following the brain surface. Okay, so this is not the convex shape of the epidural hematoma, but it is essentially concave, just kind of following the contours of the brain itself. Okay, and this is in a subdural location, just below the dura. It as well compresses the brain, but it doesn't have that dural membrane beneath it, as in the case of the epidural hematoma. Now, I put up two images here of CAT scans. On the left is an acute subdural hematoma, and we know it's acute because of how bright the blood appears, okay? It's almost as bright as the bone, and bright blood is usually an indication for more recent blood or acute blood. On the other side here, on the right side, we know there is bleeding. We can see some hyperdense areas, but the majority of the blood here is isodense, or similar in density to the brain. This is characteristic for chronic blood, okay? This is a relatively large chronic subdural hematoma. You can see that it's shifted the brain over almost 15 millimeters from the midline. This line in the middle here should really be in the normal state right on this green line, but due to this chronic hematoma, things are severely pushed over, and this can cause pretty severe neurological symptoms. Next type of hemorrhage that we want to talk about is intracerebral hemorrhage. Now, this is the first true brain bleed that we're talking about, because the bleeding is within the substance of the brain itself, okay? And these as well can be quite devastating because they actually damage the brain cells directly. There is compression of surrounding brain tissue like the others, but when you have bleeding within the substance of the brain, that essentially causes an immediate stroke. Some of the other things you might notice on this CAT scan, there is hypodensity of the surrounding brain, and we can see that for a number of reasons. There could be brain edema or brain swelling, which shows up as hypointensity on a CAT scan. There can also just be dead or dying brain tissue, which also can be hypodense. And another type of hemorrhage is the intraventricular hemorrhage. Intraventricular describes location of bleeding within the ventricles of the brain. Those are the fluid spaces of the brain, okay? So in the normal state, this is the right side of the head here by radiographic convention, right side, left side. You can see there's a large amount of acute blood. We know that because it's bright white, similar to the skull. And whereas the right side has all this blood, on the left side, you don't see as much. And this dark area is the fluid space in the brain called the lateral ventricle, okay? You see a little bit of blood in the lateral ventricle on the left side. The right lateral ventricle is essentially completely casted with blood, okay? And this is intraventricular bleeding. On this scan, you also will notice that the ventricles are larger than in some of the other CAT scans I've showed you. And that's because the bleeding within the ventricle has caused obstruction of cerebrospinal fluid flow. And that happens because blood coagulates, it's thick, it prevents reabsorption and flow of cerebrospinal fluid. And that's really one of the biggest dangers of having an intraventricular hemorrhage. It doesn't cause the immediate direct brain damage that an intracerebral hemorrhage can, but it does block fluid flow, which causes a buildup, it causes increased pressures in the head, and that can eventually cause significant damage. Another type of bleeding is subarachnoid hemorrhage. And you can see the hyperdense white blood sort of in the base of the subarachnoid cisterns. Okay, it has this sort of starburst pattern, a pentagon. Okay, and classically this picture is due to bleeding from a ruptured aneurysm. Okay, So subarachnoid, that's within the layer just beneath the dura, okay? So within the subarachnoid space, sort of intercalating between those webs of membranes in the arachnoid over top of the brain cortical surface. So what are the mechanisms of brain injury? I spoke about some of them already. One that's very common is compression of the brain, which causes the neurons to malfunction. Direct destruction, which essentially destroys them. That you will see from the intracerebral hemorrhage that causes a direct and immediate stroke. And elevated intracranial pressures, which I already spoke about with the blockage of cerebrospinal fluid flow, or even compression can cause high pressures in the head, which are not well tolerated, all essentially lead to stroke, nerve cell death, neurological dysfunction if they're not appropriately treated in a timely manner. Again, the epidural hematoma causing deformation of the brain surface and compression. The intracerebral hemorrhage causing direct nerve damage within the substance of the brain. The intraventricular hemorrhage causing obstruction of cerebrospinal fluid flow and can elevate intracranial pressures very quickly because of that lack of normal flow. So how do we manage these various types of intracranial hemorrhage? These are some basic principles that are useful for whatever the compartment is that the bleeding has occurred in. Whenever we see a patient initially, we always do our ABCs. That includes assessing the airway and breathing, assuring that they have an adequate pulse, that the circulation is good, and we attend to those three things first. As soon as they are seen by EMS or are evaluated in the emergency room, we want to make sure they're breathing. We want to be sure they don't need to be intubated on a ventilator. We want to make sure their heart is beating, that we don't have to do CPR, chest compressions. We want to make sure that we have IVs in, give them fluids if they're necessary. So those are some basic things to do when you're assessing emergency management. Often in these intracranial hemorrhage situations, people have a very elevated blood pressure. So we want to know that right away. We want to be able to bring the blood pressure down if we need to very rapidly. So we certainly assess that. Coagulopathy reversal. Coagulopathy is essentially a bleeding disorder. So we want to know if they have a history of a bleeding disorder. We want to know if they're taking medications that can cause bleeding. Secondary to trauma, iatrogenic coagulopathy is very high on the list of things that can cause brain bleeding. We do have very good reversal agents for many of the drugs that people have to take as blood thinners. So we want to know what we're working with and be able to reverse that pretty rapidly with brain bleeds. We also want to be able to control the intracranial pressures, which are generally very high with brain bleeding. To do that, we do things like hyperosmolar therapy that includes medications such as hypertonic saline or mannitol. These essentially dry out the brain. They remove fluid from the brain and generally excreted through the kidneys and urine, and that takes away that kind of fluid pressure in the brain and helps to bring the intracranial pressures down. CSF drainage. Cerebrospinal fluid is one of the three components of the intracranial compartment, the others being brain tissue, and the third being blood. And then if we remove any of those three components, we can bring intracranial pressures down. So generally, we're trying to save brain tissue, so we're not removing brain tissue to bring intracranial pressures down. But the fluid is certainly something that we can remove, and we have various strategies for putting drainage tubes into the ventricles of the brain to remove cerebrospinal fluid. I can rapidly bring the intracranial pressures down. And finally, surgical intervention. As I mentioned, 3 components inside the compartment: blood, brain, and cerebrospinal fluid. If we remove the blood or the bleeding via surgical intervention, we can certainly bring the pressures down. So let's go through a couple cases of intracranial hemorrhage. This is a 60-year-old woman who presented to the emergency room complaining of the worst headache of my life. She has a past medical history of hypertension. She's a smoker, and she has multiple family members who've had brain bleeds in the past. And in fact, she takes Coumadin. So this unfortunate woman has really all the risk factors for having a very particular type of brain bleed. She's got high blood pressure, a smoker, she's got family history of brain bleeding, and she happens to be on blood thinners as well. The CAT scan that was done showed this, and from what we spoke about already, you'll know that this is a subarachnoid hemorrhage. There may even be a small component that's within the substance of the brain, and we would call that an intracerebral hemorrhage. So it's a mixed picture, but predominantly it's a subarachnoid hemorrhage. Also on this CAT scan, you'll notice that the ventricles are a little bit more plump than in the normal state. So she has a condition called hydrocephalus, and that is due to, again, blood sort of blocking the normal drainage of the cerebrospinal fluid pathways. And much of the bleeding is centered on this left side within an area called the sylvian fissure, okay? And that's a natural plane between the temporal lobe, which is here, and the frontal lobe, which is a little bit higher, but you can see some of the frontal lobe here as well, okay? And there are several important blood vessels that lie within the sylvian fissure. So we have some clues as to what this might be. We have subarachnoid hemorrhage, and we have a lot of blood where we know there are large blood vessels. So this turned out to be a ruptured aneurysm. Okay, this picture here shows a catheter cerebral angiogram. And I'll tell you, this is the carotid artery in the neck, enters the intracranial compartment here. Internal carotid artery bifurcates around about here into a vessel called the anterior cerebral artery, which you can see here, as well as the middle cerebral artery. You can see this kind of irregular balloon-like appearance here, and that's the aneurysm, okay? And that's coming off the middle cerebral artery, actually at the bifurcation. In cartoon form, you can see it here. Middle cerebral artery, this is a branch, and this sort of weak ballooned out portion of the middle cerebral artery is the aneurysm, which unfortunately ruptured in this case, okay? And when it ruptures, it causes bleeding within the subarachnoid space. If this rupture point happens to be pointing directly into the brain matter itself, you can also get a component of intracerebral hemorrhage, which she actually had. So I won't get into too much detail about how to treat aneurysms, but traditionally aneurysms have been treated with clips. Okay, these are usually titanium mixed alloy clips that we place directly across the neck of the aneurysm to prevent any further blood from flowing into it. You can imagine if the rupture site is here and you put a clip across the neck, there will be no further bleeding through that weakened portion of the aneurysm wall. And here's a video showing what it looks like in real life to put a clip across the neck of an aneurysm. This one happens to be an anterior communicating artery aneurysm, which was clipped recently here at Lenox Hill. The other strategy that can be utilized to treat aneurysms is coiling. And coiling traditionally goes through the groin to enter an artery, and that allows catheters to be guided up to the head, and little GDC coils, these are metallic coils, can be deployed into the dome of the aneurysm to prevent further blood from entering. There are some further details about how to select patients for one procedure versus the other. There will be additional lectures during the course of this series that I think will highlight how to do that. All right, let's do another case. This is a 68-year-old man who presented with sudden onset left side weakness and headaches. He has a history of hypertension, atrial fibrillation. He's on Coumadin as well. And everyone should know now what sort of bleeding this is. It's in the substance of the brain itself. So it's an intracerebral hemorrhage. You've seen this already, but there's clearly direct brain damage or stroke from this intracerebral hemorrhage, and there's surrounding hypodensity of the brain matter, meaning this brain tissue is darker than the more normal appearing brain tissue, and that is likely from a combination of brain edema as well as ischemia, or lack of blood flow to that area of brain, which in all likelihood will lead to permanent brain death or stroke, cell death or stroke in that area. Okay. Again, how do we go about treating this? You do your ABCs. It's the first thing. Assess the airway, the breathing, the circulation. Patient was found to be lethargic, not breathing very effectively. He had to be intubated, put on a ventilator. Blood pressure was very elevated, so he was given a drip to bring his blood pressure down. In this case, we use Cardine. Coagulopathy reversal, I mentioned that he was on Coumadin, which is a common blood thinner. He was given fresh frozen plasma to reverse that. And to control the intracranial pressure, which we know is high in that situation, he was given mannitol, which is one of these osmotic diuretic agents, which essentially pulls fluid out of the brain and allows you to excrete it through the urine. This patient was also a candidate for surgical intervention to remove that blood. And you can see the result of the procedure here. He underwent a craniotomy, hematoma evacuation, and this is the post-op CT scan, which is essentially showing air in the cavity where the hematoma was removed. There's also air in this space here, which is, as we know, is the subdural space. Some air tends to collect in that compartment after you do a craniotomy. So this is called pneumocephalus, meaning air within the head. And we know that when we see some air in the head like this after a craniotomy, that things are pretty well decompressed and the intracranial pressures are low. Otherwise, the brain would really be more full and likely compressed against the bone. Other strategies for dealing with intracerebral hemorrhage, we've more recently been doing minimally invasive endoscopic strategies. You can see it outlined here, whereas unlike in this case where I did a large craniotomy to remove this blood, more recent technology has allowed us to do very small openings in the skull using tiny cameras called endoscopes to navigate to the area of blood and to remove that blood with very minimal disruption of the surrounding brain. So this is one of my cases. I made a tiny incision in the scalp. You can see I did a craniotomy, meaning bone removal of only about 1 centimeter in size. And that allowed me to put a tiny scope through the opening. And this is the removal of blood clot intracerebral hemorrhage through that tiny opening. All right, let's look at another case. 70-year-old man presents with a 1-month history of multiple falls and left-sided weakness. He has a history of hyperlipidemia and hypertension. He's on aspirin. Aspirin is a mild blood thinner. It's an antiplatelet agent. This presentation is relatively common for elderly people who are on blood thinners. They have multiple falls over the course of several weeks. Then you get a CAT scan on them, and they have what appears to be I would call this a subacute subdural hematoma. Okay, again, it's kind of following the contours of the brain. It's not an epidural. Epidurals tend to push the brain inward and are convex, whereas the subdural is concave, following the surface of the brain. This is a subacute hemorrhage. There are some brighter areas that we could call acute, but for the most part, it's a little bit tough to distinguish between the density of the brain and the density of the hemorrhage itself, and that's characteristic for subacute bleeding. The measurement of this subdural hematoma is almost 2 centimeters. You can see the brain is shifted over. This is the midline here. I didn't measure it directly, but it's, I would say that's probably about 15 millimeters of brain shift to the contralateral side. And that likely explains why he's been having all these falls and the left-sided weakness. Severe compression to the right hemisphere will initially cause weakness on the left side of the body. So this patient underwent Burrhole evacuation. And what that means is I put 2 little holes the size of a quarter in his skull. I put 1 hole here, another hole here, and then I irrigated this blood through from 1 hole to the other. And this is the result that you get. Now you can actually more clearly see the gyri and sulci on the right hemisphere because it's not as severely compressed. You see these sulci here, whereas over here, you barely see anything. There's so much compression and elevation of the intracranial pressure. And in fact, after the evacuation, you can see the brain has shifted back over more towards the midline. And overall, it's just a healthier looking brain. And this patient made a full recovery. Here's another case. This is a 75-year-old woman presented to the ER obtunded. I'm sure you guys all know what kind of bleeding this is, although it can be a little bit confusing. On the right side, you can see the frontal horn of the lateral ventricle, whereas on the left side, you can't really make it out. So probably on first glance, you thought this was an intracerebral hemorrhage, but in fact, based on the asymmetric um, uh, uh, location of this blood in an area where the frontal horn of the lateral ventricle should be, you know this is going to be an intraventricular hemorrhage. And this is predominantly in the frontal horn of the ventricle. Here you see a little bit of bleeding. This is also the lateral ventricle, but it's the temporal horn of the lateral ventricle. Okay. So in this case, a hematoma evacuation was performed. So the blood within the ventricle was removed, and you see this hyperdensity here. That's not blood, that's a catheter that was placed into the ventricle to allow continued drainage of cerebrospinal fluid to bring the intracranial pressures down, and really just to get rid of any additional postoperative debris that might cause obstruction after the surgery has been performed. Case 5 is a very recent case this week that came into our ER. A 22-year-old man, so very young guy, no significant past medical history. He collapsed at work. When he arrived, he was immediately intubated. As you know, ABCs were done. The airway was not good. He was not breathing effectively, not oxygenating. And so he was put on the ventilator. His examination was this: pupils 8 millimeters and unreactive. He had no brainstem reflexes. What are brainstem reflexes? Things like what happens when you flash a light into the eye. The pupils should constrict. In his case, his pupils remained dilated at 8 millimeters and fixed, so they had no response to light. Other brainstem reflexes, things like a cough response. If you put really anything in the back of the throat, someone with a cough response should cough to that irritation. It's a reflex. It's a brainstem reflex. This patient, unfortunately, did not have that. What other brainstem reflexes are there? There's a corneal reflex. If you stimulate the cornea of the eye in someone with an intact brainstem, they should blink. Unfortunately, this patient didn't have that either. And he had no peripheral response to pain. In a normal person, they will lift their arm or move in response to a command. So if I ask you to lift your hand, you'll lift it. In someone who's obtunded, they may not do it to command, but they may do it either spontaneously or they may do it to pain. In this case, this patient had no response at all to deep stimulation and pain. It was essentially flaccid. So this is a really a poor prognostic sign to have this sort of examination. But in any case, we went off to CAT scan to see what was going on. And you can see here, you know now what sort of bleeding this is. He had both an intracerebral hemorrhage as well as a subdural hemorrhage. So he had two components to his bleed. And these two scans here are what's called a CT angiogram. And that is a CAT scan done with contrast, and it should highlight the blood vessels feeding the brain as well as in the brain itself. So you can see here in the neck, these blood vessels are highlighted very well. However, in the head, you see almost no blood vessels in the right hemisphere. And you see some contrast within the blood vessels of the left hemisphere, but once you past this area, you don't really see any blood vessels at all. So this is very abnormal. It's a poor prognostic sign indicating that really his brain is not getting adequate perfusion, but it is in fact consistent with the very morbid neurological exam that we recorded. This patient unfortunately herniated, and that means he has had such severe compression from this hemorrhage and the associated brain swelling or brain edema that he compressed his brainstem to a degree where it no longer functions normally. And it essentially resulted in him being pronounced brain dead. And so, unfortunately, he was not a candidate for any type of surgical intervention given how poor he presented to us. But fortunately, someone else was able to benefit. He did become an organ donor. So that's just a reminder of how devastating these types of bleeds can be. There are other categories of, well, I should say etiologies for brain bleeding. Arteriovenous malformation is an interesting one. You can see the hemorrhage here. It's an intracerebral hemorrhage, but what caused it? On an MRI, we see these squiggly blood vessels. On an angiogram, you can see there's this abnormal tangle of blood vessels. Here is it in a cartoon diagram. This is an AVM, which you'll get a talk on later on in the series. I won't go into too much detail now. Other categories of things you might hear about. This is a vein of Galen malformation. This is a carotid cavernous fistula. These are dural AVMs or dural fistulas and cavernomas. These are all blood vessel abnormalities in the head that can cause bleeding. So aside from things like trauma or aneurysms or that due to taking blood thinning medications, these are some other common things that you'll hear about in other lectures. And I mentioned craniotomy and some of the medical management approaches, but there's some other things that I think you'll hear about as well, including really non-invasive focused radiation called gamma knife, which can treat some of these vascular lesions. And more we're doing minimally invasive things like laser ablations to treat various malformations in the brain, such as cavernomas. And I think you'll hear about these in more detail in those specific talks. So that was the introduction. I hope that piqued your interest a little bit, and I'm happy to take some questions. Let's see. Randy or Joshua, are you moderating these questions?
There's going to be a lot of questions coming in typically in the chat. If you want to if you see any that you think you could answer easily, go for it. But like, they'll just send it to the chat.
All right, let me take a look at the questions here. All right, so Anna asked, in the CAT scan, the white in the ventricles, is that plexus? Okay, so there is a choroid plexus. Choroid plexus is really this kind of vascular structure within the ventricles that is the site of production of cerebrospinal fluid. And yes, on a CAT scan, you can see the choroid plexus. It can be calcified in some situations and it will appear white. So it's going to be important when you're looking at a CAT scan to distinguish between bleeding and choroid plexus. And so obviously the clinical situation will guide you to distinguish the two. Let's see. This is Nishanth. Question, given the deadly increases of intracranial pressure that are possible, how much time would you have to spot and stop bleeding before damage occurs? Well, Nishant, there really is no specified time frame. You try to treat intracranial bleeding and elevated intracranial pressures as soon as you can. The sooner the better. And there's a phrase in our field that says time is brain when you're dealing with stroke. Okay, and so we try to treat these patients before they get to the point of herniation, which is unfortunately what happened in the last case that I showed you. And that happened pretty quickly. I think the time between that last patient getting to the emergency room and him having that examination was in a matter of an hour. So the deterioration can be really fast. Let's see. Haley asks, what causes chronic hemorrhages? Well, Haley, if you're referring to a subdural hematoma, it can be caused by many things. The most common being trauma, meaning you fell, you hit your head. Obviously, you had to have an acute bleed, but maybe it didn't cause too much trouble initially, and so it was left alone. And over time, blood will become chronic. Instead of having that really white, hyperdense appearance on the CAT scan, it'll go through a subacute phase where it essentially has the same color as the brain tissue, and then it will become hypodense or chronic if left alone. Now, it never really gets to that phase if you remove it in the acute phase. So just to answer your question, most common cause of really all brain hemorrhages is trauma, but there are other mechanisms, vascular malformations, AVMs, taking blood thinning medications. So there's a wide variety of things. Let's see. Samil, under what conditions can someone experience a brain hemorrhage and have no life-threatening effects or need for surgical intervention? Well, it's actually quite common to have small brain bleeds that require no intervention. Very commonly we see patients who might present with just a very mild headache. You get a CAT scan and there's a small subdural hemorrhage or even a small intracerebral hemorrhage, which we know causes immediate stroke and death to the brain tissue around the bleeding. But if the pressures within the head are not elevated and if they don't have any evidence of very elevated intracranial pressure, we often manage them medically, which means they don't need surgery. They just need usually to be monitored neurologically. If they're on blood thinning medication, we usually reverse or stop those medications. We make sure their blood pressure is in a normal range. And so it's actually quite common to see brain bleeds that require no surgery. What you want to do in those cases is really prevent further bleeding, which we do by monitoring and treating the things I just mentioned. We have another question here. Cecia, is blood coagulated in a chronic hemorrhage since it's darker in color? So in a I assume you're talking about the subdural. Blood coagulates relatively quickly, within minutes. Okay, so that blood is coagulated even in the acute setting. A chronic hemorrhage is really one that has moved to the phase where the body has started to break down the red blood cells, and we're really no longer talking about coagulated blood in that situation. It's mostly old breakdown blood products that are actually much thinner and easier to drain than the thick coagulated acute blood. Andrew asked, is it possible to have an intraventricular hemorrhage in both lateral ventricles? Yeah, absolutely. Again, the most common cause of an intraventricular hemorrhage, just as in all the other types of hemorrhages, trauma, you hit your head or you had a car accident, something of that nature. But if you're on a blood thinner, I've seen it. If you have very elevated blood pressures, I've seen intraventricular hemorrhage where it casts both of the ventricles, or actually both lateral ventricles, the third ventricle and the fourth ventricle. And that's a very dangerous situation. Generally, that is treated by putting in a ventriculostomy drain. If for whatever reason the blood is too thick to drain through the ventriculostomy catheter, then sometimes surgery is necessary. All right, let's see.
Hey guys, how we doing?
Hey, we're just answering some of the panel questions.
Excellent.
All right.
So, Jason, it's up to you if you want to continue answering questions for now, or if you want to give everyone a 5-10 minute break before the next lecture comes on.
Yeah, that sounds like a good idea. So, thank you for your attention. I hope you guys enjoyed this introduction to intracranial hemorrhage, and I'm sure I'll see you again for another one of the lectures in this series. Thanks, Randy.